Understanding U.S. Healthcare. System structures and costs. The structure of the United States healthcare system is very complicated. There are many issues associated with the payers, with fragmentation, with patient problems of getting access to care. Finance is so expensive. All these issues sort of build up to make ours the most expensive healthcare system in the world. We spend a lot of time in this semester talking about the iron triangle: cost, quality, and access. We also talked about the combination of quality and access being population health and the interventions necessary in the health system to keep communities healthy. We talked about the combination of costs and quality being the value to the health system. Reducing costs or improving quality can improve the value of overall health care in the United States. The combination of costs and access is equity, enabling access to health care at a reasonable cost. This is another way to look at increasing health care cost. The national health expenditures in billions over time. This is another way to look at healthcare spending. This is a proportion of the total economy. It's called GDP, or Gross Domestic Product. And you can see since 1970 to 2021, we've had a divergence with all the comparable country averages for what they spend in healthcare. That's a problem. Unfortunately, what we spend on healthcare is not getting us results. There are two charts on this slide. The first is life expectancy at birth in years from 1980 to 2021. As you can see, there's been a divergence between the United States and other countries in terms of the average life expectancy at birth. The United States, of course, had a big decrease over COVID, but the main thing to see here is that life expectancy is much better in other countries. In addition, the dollar spent for attaining our life expectancy is way out of whack. The comparable country average is much higher in terms of life expectancy, but much lower in terms of cost per capita for healthcare. The United States spends exceedingly more than the rest of the countries on average, and we get a lot less to show for it in terms of life expectancy.
Here's another look at our healthcare spending in terms of a percentage of our gross domestic product, which is a measure of our total economy. As you can see, we spend much more than the other countries in proportion to the total economy. Over 17% of our GDP is spent on healthcare. Most other comparable countries are around 10% GDP. So the value of U.S. healthcare is very low. This chart by the Commonwealth Fund demonstrates this analysis. In this chart, the performance of quality is on the vertical axis, and the cost of medical care is on the horizontal axis. According to their analysis, the U.S. performs poorly, landing in the bottom right-hand corner: low quality, high cost. The main goal of the Affordable Care Act was to reform the insurance market. However, there are some very important provisions that intended to improve the value of health care in the United States. The STARS Pay for Performance program bonuses Medicare Advantage health plans for meeting certain quality performance measures, such as blood pressure control. The Medicare insurance plans are even more invested in assuring high-quality health care, in addition to making a profit, because the STARS performance ranking can significantly impact their enrollment and thus their financial success. Comparative effectiveness research. ACA provided funding for research into what can be called pragmatic trials. The idea is to research whether a certain treatment intervention is significantly better than another treatment for a particular subpopulation. This is different than studying whether a treatment works, like they do in clinical trials for new drugs. Comparative effectiveness research wants to know whether the intervention is better compared to another treatment. There is a chapter on this topic in your textbook if you're interested in reading more information. And finally, we'll discuss accountable care organizations in the next lecture. But CMS, Centers for Medicare and Medicaid Services, hopes that it improves value by improving coordination of care, especially for chronic diseases, increasing transparency and accountability for providing high-value health care, and finally has some payment reform elements that we'll discuss shortly. The term accountable care organization was coined at a MedPAC meeting in 2006, and during a discussion on the need to focus on shared accountability of patient care. ACOs have since become a part of the Affordable Care Act. Although the name ACO is new, the ideas incorporated into developing ACOs have been around for decades. ACOs apply to Medicare patients only, and the Centers for Medicare and Medicaid runs the program. Unlike an insurance plan, there is no active enrollment into an ACO. In fact, the beneficiaries probably are unaware of their enrollment, and this is called passive enrollment. CMS passively enrolls Medicare beneficiaries who get most of their care from an ACO's market area, and they enroll them only one beneficiary in one ACO. The formal name of the program under Medicare is called the Medicare Shared Savings Program, MSSP. In a previous lecture, we talked about pay for performance as a way to improve healthcare value in the U.S. Well, the Medicare Shared Savings Program model is an example of P for P, or as it's sometimes called, value-based purchasing. The ACO Pay for Performance program began in January of 2012, and there are now hundreds of ACOs operating that cover millions of Medicare beneficiaries.
Comparative healthcare systems.
Why should we study different healthcare systems? First, many countries have constructed programs that predate U.S. programs by decades. There's a wide variation in programs and experiences that's worth discovering in and of itself. Second, even with the implementation of the ACA, the U.S. system has some huge holes in coverage compared to many other systems. Also, most health outcomes are better in other countries, while they spend less of their GDP on health care. As a general principle, it's always a good idea to understand other approaches to provide important clues to assessing our own system. As you'll learn, many industrialized countries either provide health care directly through the government or publicly funded health insurance with comprehensive coverage, or both. Some countries support private insurance market approach with a state subsidy. Countries with traditional sickness insurance are Germany, Austria, Belgium, France, Luxembourg, and the Netherlands. Those with national health insurance are Canada, Finland, Norway, Spain, and Sweden. These are called single-payer systems. Countries with national health services where the government also provides the healthcare delivery are Denmark, Greece, Italy, New Zealand, Turkey, and the United Kingdom. Mixed systems contain elements of both traditional sickness insurance and national health insurance. Countries with mixed systems include Australia, Iceland, Ireland, Japan, Switzerland, and the United States.
How universal health insurance works. In countries like the United Kingdom, National Health Services provides health care. Not only does the tax revenue pay for the health insurance, but also owns the services, the hospitals, and mostly employs doctors. With sickness insurance, the government runs the health insurance fund, but is financed by payroll taxes, employers, and employees. This includes Germany, where private doctors and hospitals provide the services. National health insurance, like in Canada, every citizen pays into a national plan, and there's a single insurance company, the National Health Insurance, so it's publicly funded, but privately delivered.
We've reviewed only 4 healthcare systems in the world. These systems offer parallels to elements of our complicated healthcare system. For example, our Veterans Affairs healthcare system, or the VHA, is similar to the healthcare system of the UK. The VHA is a single-payer system where the providers are employed directly by the VA, just like in Great Britain. Just like in Canada, American Medicare is a single-payer system where the providers, or the physicians, are not directly employed by the government. The German sickness funds are very similar to the employer-provided health insurance under which most Americans are covered. With the Affordable Care Act, now there's a mandated approach with a standardized comprehensive coverage found in the health insurance marketplaces. The Japanese system, typified by tightly controlled healthcare service prices, is similar to our state-based Medicaid insurance programs. Each state-based Medicaid sets prices, and in an effort to control costs, the prices are typically very low.
The United States is the only high-income country that does not guarantee health insurance coverage. As you can see, relative to other countries in the OECD, which are economically sophisticated countries, such as the UK, Germany, and New Zealand, the United States has relatively fewer in both government programs and in commercial or voluntary health insurance programs. The American paradox. Americans spend the most money on medical health care, yet have the worst outcomes of all the industrialized countries in the world. This chart shows that the life expectancy at birth is actually amongst the worst. Infant mortality, amongst the worst. Unmanaged asthma, in the middle. Unmanaged diabetes, amongst the worst. Safety during childbirth, amongst the worst. And heart attack mortality, about in the middle. These are not results that you would expect from spending the kind of money that we do on healthcare. The healthcare workforce. We will be discussing the U.S. healthcare workforce in this course. The number of U.S. full-time, year-round workers in healthcare occupations is dominated by registered nurses. Millions of nurses participate in healthcare settings, from hospitals to home health to other types of healthcare settings.
Health administration is needed to help large organizations, such as hospitals, meet goals and manage the resources, such as humans and supplies, etc. We'll talk more about healthcare management in a future lecture. If the career area interests you, please contact me regarding the USF programs, Master of Health Administration and Master of Public Health with a concentration in healthcare organizations and management. Health administration occurs in direct and indirect healthcare settings. Direct care settings include those organizations that provide care to patients. Among those in healthcare settings, about a third work in ambulatory care, almost half in hospitals, and the rest in long-term care. Indirect care are those sub-industries, such as durable medical equipment manufacturers, managed care organizations, pharmaceutical companies, and the like.
The United States healthcare system is really struggling with workforce shortages. What was already a bad situation was made worse during the COVID pandemic, and now we are left with millions of open jobs. 45 million people reach the age of 65 or older, needing additional 2.8 million healthcare workers by 2025. This is really stressful because as people age, they need more healthcare services than ever, which will compound the problem. So people resigning from healthcare generally and the aging population makes two problems even worse.
Nurses. According to the Bureau of Labor Statistics, there are 2.5 million nurses practicing nationwide, making nursing the largest workforce within the healthcare industry. Nurses practice in all healthcare settings, hospitals, medical practice, health plans, hospice, and more. There are many levels of nurses that depend on their level of education and scope of practice, from LPNs to associate degree registered nurses, bachelor's prepared RNs, and doctors of nursing practice. We'll talk about the nursing profession in the Health Workforce lecture. The nurse-physician relationship. Nurses are responsible for establishing plans and directly caring for patients. Physicians make diagnosis and treatment decisions. Nurses say they want physicians to acknowledge the importance of the nurse's role in the healthcare team. In hospitals, nurse staffing is the largest category of hospital costs. As such, hospitals are concerned with what's called the patient-to-nurse ratio. Depending on the medical or surgical unit, the recommended ratio ranges from 3 to 10 patients for each nurse. To control costs, hospitals can raise the number of patients per nurse to improve profitability, but the consequence is nurse burnout, job dissatisfaction. Ratios are not only related to job satisfaction for nurses, but also patient outcomes, such as mortality.
According to the American Medical Association, 30 years ago, 40.5% of the physicians were in solo practice, but by 1994, this percentage had fallen to 29%. Recently, though, solo practices made up of only 15% of all provider practice types. While being the only boss may have been attractive at one time, many physicians prefer sharing the call schedule. That is, they want a break from the midnight patient calls. The single specialty group, 43%, was still the most common. Multi-specialty group practices make up about a quarter of the U.S. physicians' practice arrangements. And a small minority of physicians, but growing, are direct hospital employees at 8%. Some are employed by academic medical center faculty practice plans at 3%, and some work at ambulatory surgical centers, urgent care facilities, HMO or managed care organizations, or medical schools at 6%.
Government as a provider. The healthcare function of the government varies depending on the characteristic of the group receiving care. The Veterans Health Administration and TRICARE cover veterans and active service members respectively, and the Indian Health Service provides health services to Native Americans. At the state level, community health centers are public health facilities operated by state or county. CHCs, or community health centers, are local, nonprofit, community-owned healthcare providers serving low-income individuals in medically underserved communities. CHCs may also be known as Federally Qualified Health Centers, or FQHCs. They are located in areas where primary care is needed but usually scarce, because the market does not find it profitable enough to move into those areas. CHCs provide an important access to care for millions, regardless of their insurance status or ability to pay. This is what we call our healthcare safety net. Many states operate hospitals to provide care for vulnerable populations, such as the indigent or mentally ill. In Florida, an example of a Florida state hospital is in Chattahoochee, which is northwest of Tallahassee. Also in Florida, state mental health treatment facilities are operated through the Department of Children and Families. Local community health programs provide preventive and primary care. For example, voters in Miami-Dade County approved a referendum in late 2013 that provided $830 million in funding through property taxes for new construction and equipment of the Jackson Health System. Jackson has a reputation as a safety net provider of free care for vulnerable people in the Miami-Dade area.
The provisions of the Affordable Care Act are designed to address problems with rising costs and problems with access to health care for many individuals, insured and uninsured. The legislation addressed holes in the system that created barriers to affordable care and access by protecting consumers of health insurance, improving quality of care, lowering costs, and expanding access. I'll discuss each of these concepts in turn in the remaining slides.
As of the summer of 2023, 41 states, including D.C., had adopted the Medicaid expansion, and 10 states have not adopted the expansion. Determinants, barriers, and access.
Multiple determinants of health. Let's start with the textbook's infographic describing the multiple determinants of health. In your other College of Public Health studies, such as hc 4211, Health, Behavior, and Society, you undoubtedly encountered the concept of the ecological perspective of health before. Over our lifetimes, various conditions impact our health, from our genetics to our social and economic environment. And this makes intuitive sense, but in the past, our medical system has focused predominantly on disease diagnosis and treatment. This reactive stance to health is being slowly replaced by a more proactive effort to understanding the multiple determinants of health. In this lecture, I hope to expose you to population health insights about the U.S. healthcare system that may be new to you. Okay, so back to the county health rankings model. According to their methodology, there are 4 categories of determinants that contribute in various weights to mortality and morbidity. I'll present examples from some of the categories that show how the research discipline of Health Policy and Management Department, we call it Health Services Research, is challenging the medical model in an effort to improve the population health of the United States. First, I will briefly talk about the social and economic factors using the examples of the famous Whitehall studies. Next, in the context of health behaviors, I'll present information about something called the Chronic Disease Self-Management Program. When looking at clinical care and physical environment components, I will share the Dartmouth Health Atlas research on local area variations in health services utilization.
The upstream factors that make us sick are called social risks. Poverty and unemployment, transportation barriers, lack of education, housing instability, food insecurity, and social isolation are all social risks that contribute to sickness. So now we're going to talk about social determinants of health, and I'll start with a parable. Imagine 2 people sitting riverside, watching the water flow, the rapids moving quickly across from one side to the next. And then they notice a person drowning. So they both jump into the river to save the person. They drag him to the side, and that was very stressful. Then they see another person just floating down the river, drowning. So they jump in to save the next person and drag him to the riverside. And then when the third person is floating down the river, one person, instead of jumping in the water to save him, runs upstream, and the other says to them, "What are you doing? Where are you going? Help me save this person." And that person running away says, "I'm going upstream to see why they're falling in the river in the first place." Social determinants of health are about running upstream to see why people are getting sick in the first place.
As a final topic of this lecture, I want to share with you the concepts related to racial and ethnic disparities in population health. Before I do, please understand the concepts of race and ethnicity are very complex, and I hope you encounter these concepts in greater depth in other courses. So first, to quote writer Ta-Nehisi Coates from The Atlantic, no coherent fixed definition of race actually exists, and that our notion of race and ethnicity is a product of social context. However, as Kamara Phyllis Jones puts it in her chapter in Race, Ethnicity, and Health, a public health reader, race is a proxy for specific historical experiences and a powerful marker of the current social and economic conditions that determine the exposure to pathogenic factors. In other words, The measure of race and ethnicity are messy, but it's the best we have for understanding health disparities in the United States. Racial and ethnic disparities in health have been a persistent problem in the United States. Infant mortality disparities has been apparent since researchers started looking at it more than 100 years ago. There are persistent racial and ethnic disparities in cardiovascular disease. There are persistent racial disparities in HIV infection. There are persistent racial and ethnic disparities in flu vaccinations in California, where blacks compared to whites have a much lower uptake of the flu vaccine. Racial and ethnic disparities are also pervasive. So, for example, let's examine the COVID-19 pandemic rates of cases and deaths. In Chicago, more than half of COVID-19 cases and almost 70% of the COVID-19 deaths involve African Americans, who only make up 30% of the population. In predominantly African American U.S. counties, the COVID-19 infection rate is more than threefold higher than in predominantly white counties. New York City, as of May 7, 2020, had a greater age-adjusted COVID-19 mortality rate among Latinos and African Americans compared with white residents, almost twice as much. According to scholar Eduardo Bonilla Silva, racism can be defined as an organized social system in which the dominant racial group, based on an ideology of inferiority, categorizes and ranks people into social groups. We call these social groups races. The dominant racial group uses its power to construct barriers to resources and opportunities to groups defined as inferior. According to the American Public Health Association, or APHA, racism hurts the health of our nation by preventing some people the opportunity to attain their highest level of health. As an example, one of the main ways racism is expressed in population health is through segregation. Segregation concentrates communities of poverty with high levels of neighborhood disadvantage and low quality housing. According to an annual review of public health article, the physical and social conditions lead to elevated exposure to physical and chemical hazards, increased prevalence and co-occurrence of chronic and acute psychosocial stressors, and reduced access to a broad range of resources that enhance health. There are other forms of racism too, such as structural racism, cultural racism, and discrimination. Some communities are declaring racism a public health issue, which illustrates how changing the view of racism may lead to positive change. APHA also recognizes that a disproportionate number of people of color, particularly black people, are subjected to police violence each year. From APHA's perspective, previous interventions that attempted to reduce violence by police, such as community-oriented policing and training, body or dashboard-mounted cameras, were evidently not enough. These approaches lack a primary prevention, public health frame. Instead, APHA recommends that governments fund programs that meet human needs, promote healthy and strong communities, and reduce structural inequities, economic, racial, social, such as unemployment initiatives, educational opportunities, and affordable housing, including by using resources currently devoted to law enforcement.
But more research needs to be done on racism and health outcomes. In fact, more research is being done on racism and health outcomes. Leading the charge is David R. Williams. Dr. Williams is a leading scholar in the impact of racism on health outcomes. And he's saying increasing evidence indicates that racial discrimination is an emerging risk factor for disease and a contributor to racial disparities in health. There is a need to research how exposure in more than one domain, cultural, institutional, individual relates to each other, and to combine to affect the adverse impact of discrimination on physical and mental health. I recommend that you search for David R. Williams. His TED Talk is very impactful. Health equity, assessment, policy development, and assurance are each focused on improving equity in our society. To achieve health equity, the essential public health services actively promote policies, systems, and overall community conditions that enable optimal health for all and seek to remove systemic and structural barriers that have resulted in health inequities. The contrast between equality and equity are illustrated in this image on the slide. Equality equals sameness. Equity, however, is about fairness.
Access to health care can be defined as the ability to obtain specific health services, such as medical or surgical care, dental care, prescription drugs, mental health care or counseling, and eyeglasses. One of the most important enablers of access to care is health insurance coverage. We've talked about health insurance quite a bit in this semester, and we'll discuss it some more in this lecture. Access to health care is determined by more than just insurance status, though. Insurance is useless if there are no providers to care for the sick or beds to occupy when care is actually needed. An alternative measure related to access is healthcare capacity. More commonly, healthcare access is measured by asking representatives sample whether they have a usual source of care. This really means if you need healthcare services, is there a place or a person you usually get care from? Similarly, surveys ask whether a person has ever postponed or went without needed care. Finally, a measure that is increasingly being used for access to care is whether the emergency department is being used for ambulatory care sensitive conditions. This is an academic way of saying, did the patient use the ED when they should have used the ambulatory or primary care setting? Examples include chronic diseases, such as hypertension, or common ailments, such as cold viruses.
Social barriers, such as poverty, the lack of health insurance, unemployment, transportation, lack of education, and racism, are associated with poor access to care.
This figure from Kaiser Family Foundation explains the problems that not having health insurance create for access to care. This chart shows that the lack of health insurance is the biggest reason for people not having a regular doctor or getting the needed care. Specifically, they are more likely not to have a usual source of care, to postpone needed care, go without needed care, or not be able to afford prescription drugs. The text presents many barriers that inhibit optimal medical care. I will highlight two of them. Complexity is a major barrier. Early in the semester, we talked about the requirements of the free market. An important requirement of a free market is that both the buyer and the seller have perfect information to make purchasing decisions. And that's not possible with the complexity of medical knowledge. The patient can't keep up with all the treatment options and possible outcomes. Even the physicians can't keep up. A need is developed for specialists and super specialists. Also, there are many different healthcare payers or insurers. This means that the payments, claim submissions, and oversight requirements can vary from one payer to the next. Insurance plans, both public and private, require quite a bit of paperwork, adding to the healthcare costs. Their contracting strategies require a lot of information when negotiating payment rates that the hospital will accept, and this also adds an incredible amount of complexity. Our system is also fragmented. Physician silos means that care is not integrated among specialists. Knowledge must be shared between fields since patients often have more than one disease and see more than one type of specialist. We also do a very poor job of coordinating care for patients. As I've presented before, the U.S. healthcare system is oriented towards fee-for-service. Payments must be changed so that physicians will take the time to talk to each other, something that insurance companies don't pay for. According to Kaiser Family Foundation, 20% or more of total healthcare expenditures are due to various forms of waste, including overtreatment, failures of care coordination, failures of care delivery, administrative complexity, pricing failures, and fraud and abuse.
Benefits of integration. Integration is the opposite of fragmentation. In general, greater integration make it possible for a system to better understand and design programs to meet the comprehensive needs of a population so as to improve the quality and efficiency of care. Case study organizations are taking multiple paths to integrating care, bringing together providers and services across disciplines and settings to focus on particular conditions or care episodes, such as diabetes or cancer or cardiac surgery. They also may do this across time and types of care, such as using every patient contact as an opportunity to schedule a needed preventive care. Fully integrated systems, such as Kaiser Permanente, find that owning hospitals and co-locating services in medical centers promote tighter care coordination and efficiency. Likewise, critical access hospitals in rural communities often serve as a one-stop shop for integrating inpatient and outpatient care.
In this lecture, I'll present some of the solutions to complexity and fragmentation through the organization of medical care delivery. There are new types of provider organizations intended to solve coordination and cost problems, including patient-centered medical homes, accountable care organizations, and integrated health systems. As opposed to the acute and treatment-focused model of care, other care models are being implemented, including chronic care model and chronic condition self-care, the team-based medical practice, and health navigation. And finally, I'll present information on how improved financial incentives are being incorporated into these medical care delivery models. The roles of healthcare managers.
This slide contains the definition of management. It's simply an organized way of getting things done with the right information, resources, and people at the right time. It's the process that organizations use to make important decisions. And according to Harold Kuntz's The Management Theory Jungle, it's getting work done through others, done properly, on time, within budget. It is the process composed of interrelated social and technical functions and activities occurring within a formal organizational setting for the purpose of accomplishing predetermined objectives through utilization of human and other resources. There are three primary objectives of healthcare administrator. First are the business and financial aspects of the healthcare organization. This includes assuring that the service is delivered efficiently and effectively. I'll present these important concepts later in the lecture. The business roles of healthcare managers include human resources, financial management, data collection and analysis, and strategic planning and marketing. Next, healthcare administrators are responsible for the care of people at their most vulnerable, when they're dependent on the health services of the organization. Finally, healthcare managers are responsible for the moral and social order of the organization. They must advocate for patients, arbitrate when values conflict within the organization, and act as an intermediary between various professional groups.
Unlike clinical professions, health administrators are not required to have licenses. No license is required, so that threatens the professionalism of healthcare administrators. We lack the exclusivity afforded to clinicians who earn their practice license, such as medicine, nursing, and allied health professionals. As a result, we have sort of a quasi-profession status. As a result of no licensure, we sometimes are subordinate to the clinical professions in the social and political structure of the healthcare organization. This means that we need to behave with a certain level of professionalism to retain the respect and power afforded to those with licenses. Healthcare managers also have a tremendous amount of responsibility compared to the management profession overall. Responsibilities that are uncommon in most other industries include the intense regulatory oversight in healthcare, around-the-clock demands for services, and life and death consequences of our decisions. With the important responsibilities of the healthcare manager comes the opportunity to work on the interprofessional team. Interprofessionalism is what happens when individuals from multiple health disciplines collaborate to deliver care. Interprofessional education has been defined as situations where two or more professions learn with, from, and about each other to improve collaboration and the quality of care. Clinicians often misunderstand the role of the health administrator, partly because there are contradictions in the role of the healthcare manager. In these next few slides, we'll discuss the contradictions in healthcare management. Healthcare managers balance the need to plan, organize, direct, and control with the need to react to everyday management challenges. Healthcare managers uniquely contribute to patient care, often without detailed clinical knowledge. Healthcare managers combine the art of leading people with the science of evidence-based management. Healthcare managers embrace the need to create profits, but also serve the community. Healthcare managers control costs, while at the same time improving patient care quality. And there's a science to healthcare management. Something called evidence-based management means that translating principles based on scientific evidence into organizational practices. That means identifying the best practices, what works objectively, and then implementing that. Good quality decisions should be based on the combination of critical thinking and the best available evidence. This rigorous approach to management complements the art of working with people. Evidence-based management is an expression of the more logical, analytical mind that healthcare management requires.
Effectiveness and efficiency are very important concepts in the study of healthcare management. Effectiveness measures the degree to which goals are achieved. Another way of saying this would be goal attainment. Efficiency, on the other hand, refers to producing the largest results for a given amount of resources. Efficiency reflects the greatest benefit at a given cost. Efficiency recognizes that resources are constrained, so we need to realize the biggest bang for the buck.
Managers are also responsible for giving feedback on performance at the organizational level and at the individual level. The graphic shown on this slide is a performance feedback loop. The idea that you set a goal and then have actions in the task environment to accomplish that goal. Then you have performance on that goal. And then you evaluate in the performance feedback whether the performance equals the goal. In cases when the goal is not achieved, then you create new actions to try to improve the performance to meet those goals. Management is the act of setting the goals, tracking the performance, and evaluating the accomplishment of the goal. Public health.
Public health administration takes place at government and social agencies such as local health departments or child and maternal health clinics. As you've learned previously, public health focuses on prevention of disease, whereas personal health is more concerned with intervention. Practically speaking, however, the lines are blurry as more public health organizations are providing medical intervention for financial reasons. Nonetheless, a distinction can be made between public health and personal health management. The core functions of public health include assessment, such as epidemiology and research, policy, such as health planning, and assurance, which includes inspections, health education, and occupational health and safety. Finally, disaster preparedness and response is a critically important function of the Public Health Administration. It incorporates all of the core functions I just mentioned in order to manage emergencies for populations. I will present more information on disaster preparedness and response later in the lecture.
Building on the extraordinary public health successes of the 19th and 20th centuries, Public Health 3.0 is the idea that public health practitioners should work across sectors to address social determinants of health. The 21st century public health system should connect medical care system to the social care systems, such as education, food services, housing supports, and financial safety nets. Without addressing the core matters that influence our health, the medical system is destined to treat the surface issues without attention to the underlying causes.
These are the 10 essential public health services according to the CDC. The 10 essential public health services provide a framework for public health to protect and promote the health of people and communities. They include the categories of assessment, policy development, and assurance. Each of these three are contributing to or focused on health equity. You should know these 10 essential public health services for your exam. Quality management.
Quality is an important concept in healthcare, but there are many different ways to look at it. Here are some definitions that you should know. First, according to the Institute of Medicine in 1990, quality is the degree to which health services for individuals and population increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Next, quality is the right care for the right patient at the right time. According to Carolyn M. Clancy, MD, the Assistant Deputy Undersecretary for Quality, Safety, and Value at Veterans Health Administration, and she's a associate clinical professor of medicine at George Washington School of Medicine and Health Sciences. Every time should be added to this axiom. She said that it's the every time, the reliability that we are still struggling with a bit. It's very expensive. In other words, it's the variability of healthcare quality that is the problem. Also, quality is having the appropriate structure, process, and outcomes. These are from Avitas Donabedian, a physician and health services researcher at the University of Michigan. He developed the original model in 1966, and we'll talk more about these concepts shortly. Finally, quality is eliminating underuse, overuse, and misuse. The Crossing the Quality Chasm is a report published by the Institute of Medicine's Committee on Quality Healthcare in America. It focuses on closing the quality gap, the chasm, between what we know to be good healthcare and the healthcare that people actually receive. The IOM established 6 aims of quality improvement. Our efforts at quality improvement should be to deliver healthcare service that are safe, effective, patient-centered, timely, efficient, and equitable. Effective care is providing services based on scientific knowledge to all who could benefit, and refraining providing services to those who are not likely to benefit. Also, effective care is defined as care that is based on the use of evidence established by research to determine whether an intervention, such as a preventive service, diagnostic test, or therapy, produces better outcomes than the alternative treatments. To say that a healthcare intervention is effective implies an evidence base. Clinical expertise means that providers are the ones that decide the best practices. Best practice is different than medical necessity, which is decided by insurance companies. Best practices must be aligned with patient values, identified through patient goals and expectations. One patient with back pain may prefer surgery to treat the pain, while another may prefer physical rehabilitation program. Clinical expertise is used to present options to the patient. Patient-centered care. The IOM definition of patient-centered care is providing care that is respectful of and responsive to the individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. The most common framework for the healthcare quality measurement is that of Donabedian, who conceptualized it in 3 dimensions. In his 1980 paper, Donabedian wrote, "To measure quality, our concepts of what quality consists in must be translated to more concrete representations that are capable of some degree of quantification. These representations are the criteria and standards of structure, process, and outcome." What Donabedian did for the first time is urge the development of operational definitions of quality within these categories. Creating operational definitions is the process of defining an ambiguous concept in tangible, representational, measurable, quantifiable terms. As an example, how do we measure happiness? Number of smiles per day? A survey of satisfaction? There is no one way to measure happiness. Same with quality of medical care. Operationalizing healthcare quality is a painstaking process because there are many dimensions to the concept of quality that can be defined. I present each of Donabedian's healthcare quality framework concepts along with examples in the next slides. These are important to know for the exam.
Another key element of quality that is not mentioned in Donabedian's healthcare domains is patient experience. Patient experience effectively means patient satisfaction, but not with healthcare outcomes, more with the total experience of care, including communication with nurses, communication with doctors, responsiveness of hospital staff, the cleanliness of hospital environment, quietness of hospital environment, overall hospital rating, and a recommendation of the hospital. This information is collected through a standardized survey conducted by Press Ganey but overseen by the federal government called HCAHPS, Hospital Consumer Assessment of Healthcare Providers and Systems. There are many different types of CAHPS surveys for different settings, including outpatient, ambulatory surgery, and managed care.
There are many promising quality initiatives in the U.S., such as transparency through improved public reporting, use of checklists to improve care outcomes, amassing evidence for use by consumers or to motivate providers to improve, pay-for-performance initiatives, and broad adoption of electronic health records. I'll present additional detail on the first 2 in the next slides.
Conspiracy theories. Threats to public health communications. So let's discuss some ideas behind conspiracy theories. Conspiracy theories attempt to explain events as the secretive plots of powerful people.
Maybe for some people, we shouldn't try to advocate public health interventions by communicating science. Lewandowski et al. In 2013 found that conspiracist ideation, such as agreeing with the statement,
The Apollo moon landings never happened and were staged in a Hollywood studio, or the belief that AIDS was created by the government, is moderately correlated with vaccination fears. The researchers wrote that because conspiracist ideation leads believers to resist evidence contrary to their conspiracy theory, presenting them with scientific evidence tends to amplify that rejection.
How do you know if someone's a conspiracy theorist? Well, they probably aren't engaging in critical thinking. Your critical thinking can help you pick out the red flags of conspiratorial thinking. This from the Conspiracy Theory Handbook by Lewandowski and Cook. There are 7 traits of conspiratorial thinking, they say, that can be summarized and remembered with the acronym CONSPIRE. Is their thinking contradictory? Does one idea of the theory contradict another? Does the person have overriding suspicion? Does the theory itself say, oh, it's part of a cover-up? Does the theory imply that people are being taken or that money is the primary goal? Nefarious intent is a big part of identifying conspiratorial thinking. Something must be wrong. S. Does the theory have no solid evidence to support it? Is it just a gut feeling? Persecuted victim. P. Does the person promoting the theory feel as if the entire world is out to get them? Immune to evidence. Is the contradictory evidence viewed as simply a cover-up? Any evidence that counters the theory must be part of a conspiracy, they say. Reinterpreting randomness. Are random events interpreted as part of a pattern? By identifying conspiratorial thinking, you can understand how to approach a person about changing their mind through techniques that might actually work.
Lewandowski et al. Concede that the rejection of science has implication for science communicators, including public health professionals, and climate scientists too. So how do we communicate to the science skeptics? Factual rebuttal strategies alone are unlikely to counter the emotional appeals of the websites, such as Jenny McCarthy's organization. Sound logic typifies most scientific theories, but conspiracy theories rely on isolated pieces of evidence that are inconsistent with an official account. So citing additional studies may just reinforce their beliefs that science is corrupt. Lewandowski recommend more indirect means, such as confirmation of their competence and character despite their faulty logic. As a communication strategy, according to public health researchers, a key step is to identify those who are vulnerable to misleading information, but those that can be convinced with more interactive and customized messages. You must acknowledge that science is not infallible. In fact, the CDC continues to look at the environmental exposures, including vaccines, but are looking at other things like older siblings that had colds and mothers who drank a lot of diet soda during pregnancy. Also, sharing anecdotal evidence about the consequences is another approach. Since the results of prevention through vaccination are intangible, and measles and other infectious diseases are now rare, perhaps we need to do a better job of communicating the consequences of non-vaccination. So, let me try these pieces of advice now as an example. You are obviously a caring parent that thinks about these issues, such as vaccinations, very carefully. Many parents feel the same way. Autism is increasing, and we don't know why yet, which is scary. However, these infectious diseases are a real threat to your child. There was an outbreak in San Diego recently. Have you seen the stories from those parents? Oh, here's the website address. So, as you can see from my effort there, efforts should be made to rebut many conspiracy theories, but done in a non-confrontational manner.
Health IT. We're in the midst of what scholars are calling digital transformation in healthcare. The idea is that we use digital technologies to empower patients to become active decision makers in their medical care processes, offering information through portals and access through mobile devices. Patients who are involved and engaged with their healthcare decisions have better healthcare outcomes. In addition, we're looking to make our systems more integrated so that data can be carried from one provider to the next, from the hospital to a specialist to a primary care physician, and across all continuum of care. On these next few slides, I want to share with you some digital health technologies, such as telehealth, virtual care, patient portals, and hospital-at-home technologies. Telehealth grew 380% from before the pandemic to after, and it's since stabilized, but the big change was that Medicare now paid for primary care visits. The pandemic made what was a necessity speed up telehealth services, and to now is a staple of many primary care and specialty care and even inpatient care services. However, there are disparities in digital access. Between 15 and 24% of Americans cannot reliably access the internet or health technologies. The lack of internet access and digital literacy by racial and ethnic status is significant. Adults 65 and over are statistically less likely to be able to access the internet. Significant language barriers exist across major health platforms, and only 38% making under $20,000 have internet service. Technologies are significantly expanding the opportunity to care for patients at home. Medicare beneficiaries could see approximately 3 to 4 times more at-home care by 2025. Medicare spend on services that could be performed at home by 2025 in billions. As you can see, acute care, that is hospital care, could grow to an $80 to $125 billion. Other services are also possible for care at home enabled through technologies. Health analytics involves the collection, analysis, and interpretation of healthcare data to improve patient care, clinical outcomes, and operational efficiency within the healthcare industry. Healthcare analytics can encompass a wide range of activities and techniques, including scientific discovery, predictive analytics, clinical decision support tools, predictive analytics, and artificial intelligence. Data can also be used in clinical decision support tools, effectively allowing clinical guidelines to guide clinicians on what services to provide under certain conditions. It creates standardized workflow for the clinicians to evaluate any particular diagnosis or event according to rules set by algorithms and determined by expert panels of scientists and clinicians. It provides notifications and reminders for services. The pharmacy information systems alert prescribers of new drugs or proposing possible drug-drug interaction. This support helps reduce medical errors and improve patient quality. HIPAA regulations set the national standards for electronic transactions. The idea is to protect health information. Personal health information or individually identify health information related to the individual's past, present, or future physical, mental health, or condition. The provision of health care to the individual, or the past, present, or future payment for provision of health care to that individual. HIPAA regulations. The HIPAA privacy rule is one of the major parts of the regulation. The goal is to ensure that individuals' health information is properly protected while allowing the flow of health information. There are major civil money penalties associated with the HIPAA privacy rule, and violations can go from $127 all the way up to almost $64,000 per violation. The HIPAA security rule is a national standard to protect individuals' electronic personal health information by any covered entity. It requires administrative, physical, and technical safeguards to protect patients' protected health information. Administrative safeguards are those policies and procedures designed to ensure security measures to protect health information. Physical safeguards, of course, are regarding the equipment and systems to protect data from physical threats, environmental hazards, and unauthorized intrusion. An example of technical safeguards is controlling the access of protected health information, such as using passwords and user settings for allowing certain people to access data. Cybersecurity measures are critical for ensuring the protection and privacy of sensitive health information as required by HIPAA regulations. Cybersecurity includes data protection and encryption, access controls and authentication, and security incident response and reporting. Regular audits and risk assessments and training and education are absolutely required for organizations seeking to prevent hacks. Of course, the fines are huge and they get bigger and bigger over time. More than 90% of healthcare organizations have experienced a data breach of some type, and 34% of data breaches come from unauthorized access or disclosures. A lot of this has to do with phishing emails, allowing access into systems. And these security violations, more than 41 million patient records were breached in 2019. That's triple in 2018. Healthcare hackers are individuals or groups engaged in unauthorized access or cyber attacks targeting healthcare systems. They engage in what's called ransomware attacks, which involved malicious software that will encrypt the data, effectively blocking access to critical information until that ransom is paid. This can cripple a healthcare system, and so significant dollars is paid to invest in cybersecurity. Thank you very much for an excellent semester. Good luck on the last exam.